as mentioned, the Odyssey community gives out 7 Titan Awards each year, and we like to make sure that we give everyone a chance to really discuss kind of their work, their journey to Odyssey, and specifically what they've done over the last year that kind of earned them this honor. So I'm going to stop sharing, and I am going to start off with Song.
Thanks, Greg. Hi, everyone. So before I start sharing and do a review of my 3 slides, I just wanted to mention that it's extraordinary on how many people are on this call. If I do this with APAC people, it would be, I would say, 1/3 of this number at max. So great seeing 110 people in the call right now. And we're very quiet, like Erica pointed out, right? You guys are very attentive. Thank you for this. Another, I guess, thing to point out is I'm very nervous right now because normally it's me getting people on the podium, chasing people around rather than me being on the podium and talking to everyone. But yeah, enough of the side chat, and let me get a go ahead with the um, short presentation that I prepared. So before I speak about all the boring stuff, exciting stuff that I do, I'm Song. Big surprise. My first name is not Song, but I go by Song. I have a very difficult first name, which people don't really pronounce very well, and I really don't like to go through that 1 or 2 minutes of trying to tell people how to pronounce it. And I'm pretty sure somebody's gonna ask you, how do you pronounce it? So the Korean version is Gyeol, and the original English version that I used to go by during my childhood is Gyeol, in which both Patrick and Craig are doing a very good job at pronouncing. So kudos to that. But yeah, just call me Song. I see other songs in the call. Please pardon me. I just go by Song. Please use your first name, right? So I get the Song in Odyssey, so no other people can do that. So yeah, I'm Song. I'm a project manager at IQVIA's OMOP team. I see several colleagues here in the call with me. Nice to see you guys. That is in a call that is not related to work. Welcome, guys. I'm based in Korea, so right now it's a little bit over 1 a.m. for me, but the things we do for Odyssey, right? You guys, some of you guys here, you've been dragged into meetings very early in the morning, very late at night because of myself. So I'm going to just share back the love to you guys by being here today and speaking live. And I've been a Odyssey collaborator since 2017. So that's a pretty long period. I've seen a lot of friendly old faces and new faces. But yeah, it's great being part of this community. So going on to the next slide, yeah, you guys are probably thinking, okay, well, who is Song and what is he doing, right? I'm not sure how many of you among you guys know what I really do, but in a nutshell, I'm sort of the APAC equivalent to Craig and Elise. I hope I'm not undermining any of the work that you, Craig and Elise does. I don't know if Elise is in the call, but that's not my intention. But I guess it's more of a way to get people to understand what I do for APAC and what I represent. So I coordinate a lot of the APAC community gatherings. So like the community calls here, there's the APAC versions of this, the APAC community calls, the APAC steering committee meetings, and we have a geeky meeting series called APAC Scientific Forum, which we kicked off this year. We tried something new this year. It's going great. It's these meeting series where we try to host topics that people are either interested in or they need help with. So it's really a lot to do about research, sometimes a little bit about ETL and vocabulary, but yeah, it's going great and a lot of interest from the community. So I feel good pride in that. Apart from that, I also support in APAC Symposium plannings and logistics. I see a lot of people here that I chase around. I chased around for the recent symposium in Australia. I write and distribute the newsletters like Craig, but I do it on a quarterly basis because maybe because I have a day job. Hopefully, if we have a lot more news coming in the APAC region, we can get this maybe on a monthly scale. But I don't want to guarantee this because that's literally giving myself more work. But yeah, hopefully there'll be more news to share in the upcoming years. Another part of my role to the APAC community is disseminating these news that you guys share within these calls or the forums and sharing it back to the APAC people, right? Because not all of the APAC people are involved in the global activities. Not all of them are keeping an eye out on the forums. So what I do is I monitor this on a regular basis, try to communicate this back to the community in APAC through the calls, just like Craig did at the beginning of the call. And I also answer questions that come from the community, either directly to myself, or we have this little very superficial Odyssey APAC account, which I also monitor myself. So if you guys send an email to that and you get an answer, that's 99% me. Sometimes it's somebody else, but most of the time it's me. And if I can't answer it, I'm your person to find to find the right person to answer that question if I can't answer it myself. So last but not least, I teach occasionally at tutorials. I'm not very good at it, but I've been in the community for a long time, so I do know a few things here and there that I picked up. So I try to help out new joiners and hopefully also teach more at these tutorials, so that it can potentially get hopes to new people that they can potentially end up on the podium like other people that are teaching there, right? We don't want Patrick to be teaching 24/7 in the upcoming years, right? So hopefully we can expand this as more of a community effort. Yeah, so that's what I do. I think because of what I do, I've been awarded this community award, this Titan Award of Community Support. Thank you for this. Thank you for this award, guys. And while I'm saying thank you, right, I really want to say thank you to several people. So Mui, Sarah, Atif, and Jing, they're all my mentors at IQVIA. Thank you very much for your support. I also would like to thank the Odyssey community and the APAC leaders, which I'm pretty sure contributed a lot to the votes and enabled me to get this award. And I also want to do a special thanks to Craig and Elise, who is supporting myself, support the APAC people. So without your support, I cannot support, right? So we're sort of a chain reaction. So I really enjoy being part of this chain reaction. And last but not least, the APAC Symposium this year was a great experience for me. A lot of interest from the community. I met a lot of people face to face in a long time. So I would really like to say thanks to Nicole, who is also another Titan Award winner. But I also would like to say a special thanks to Catherine, who helped out a lot with the logistics and bared with me throughout the entire process. So I'm going to stop there. This is the end of my presentation. If there's any questions from the community, I'm happy to take them. If we have time for that, Craig. I don't want to step on your toes on that.
No, it's okay. Certainly, well, first of all, congratulations to Song, who's overly kind, but I can tell you, having worked with him, Song is incredible. And I don't think I might be a little biased in saying I think probably community support is the most important of all the Titan Awards. So, but Song's great. And if we are doing, if anybody has any questions, let's keep them to the chat, just so that we give maximum time for everybody. Now I'm going to move over to, we're jumping around just based on where people are. But the Titan Award for Clinical Applications went to the Center for Surgical Science, which is doing really amazing things. And I believe Ismail is here. I saw him. Yes, Ismail is here, and he is going to present on behalf of the team.
Yeah, hi everybody. Oh, and thank you for this possibility to present what we're doing. I was regrettably not there for the meeting earlier. Andreas was so kind to be representing our unit there, and I really feel genuinely honored, but also kind of the non-expert on all the amazing stuff that you guys are representing. So I'll try to be as true to where I think I have something that I can share with you guys that can give some meaning. Before I go on to that talk, I also want to present you another prize that I got, and this is an avatar that I got from Patrick, which is actually resembling me. But as you can see, this guy is pretty stressed. And Patrick, if you can see that this guy is holding something in his hands, and I just want to remind you specifically that I'm a colorectal surgeon, so this is a colonoscope. So whenever you want an examination, my guy is ready to do some amazing stuff with your bowels. So thank you very much for that, and sorry for this a little bit professional maybe detour that I took. So going into the framing of what we have produced from an amazing team in Center for Surgical Sciences, and also I'm representing an amazing team from our unit with Andreas, Andy, Martin, etc. So I'm really kind of a little bit uneasy to present all the amazing stuff that these guys have been making a reality. Okay, so just to give you an example of the clinical reality that we are in, and where I see the title of my talk making really sense. So doing OMOP from data source to implementation. This is 2 patients from my clinic where we it was actually in the same day, an 85 years old female and a 56 years old female. These 2 patients presented with exactly the same cancer in the sigmoid colon. And as you can see, a little bit nuanced differences in their risk profile with respect of hypertension. The both patients had that, and one of them had osteoporosis. The other one had heart failure, but well compensated. So in my clinical practice, I would, just based on the age, say, okay, the 85 years old female is definitely one with the highest risk and the shortest expected mortality or survival. But when we are running the model that we have developed based on our OMOP big data platform, based on our registry data, we can actually see that what's happening is actually that the 1-year mortality is 5% in the 85 years old female and 11% for the 56 years old female. And this is kind of framing the core of what the platform has provided us in a clinical setting, is actually to be giving us a language to predict outcomes on our patients when we are aiming to treat them in one way or the other. So at the core is personalized medicine, and this is going to be the major driver of healthcare improvements in the next decade in the decision support frame that is so rich and not limited for colorectal cancer, obviously, but also to orthopedic surgery, lung cancer, other medical conditions. So I think that what we did was kind of tapping into a data repository provided by the Danish registries and doing all the hard work to join those different frameworks in a prediction model framework, where we wanted to say, okay, if we can do this amazing work that the OMOP Common Data Model is providing for us, what would we do as clinicians to differentiate clinical care for these patients depending on a risk profile, which is what is your risk of dying within the next year if I do surgery on you. So this was actually a very important point from my side, is to involve clinicians and doctors. So if you are going to succeed, you need all the amazing guys on the data science team, and doing the harmonization, doing the standard approach that the OHDSI toolkit gives us the possibility to do. But at the same time also involve the clinicians in framing the question that we need a solution for. And this is my most important point, is to actively integrate clinicians, both in the mapping process, which we were so lucky to have. So we had, depending on the month, we had 3 to 6 different MD, PhDs, MDs that were actively validating then that the mapping that we did from the source data to the common data model was actually validated, because we wanted to use this and lift this into clinical practice. This is just an example of two different conditions. If I were to use the OMOP common data model as a patients like me platform, I would make two completely different conclusions if I were not scrutinizing how the content creation is kind of dependent on the medical interpretation. So by far we got some very good health, good help from Eden's Health and our team for optimizing the project process, but it was extremely important to involve MD. So what now we have a data repository with more than 100,000 variables that all have been kind of filtered and improved in their quality by MDIs. And what we have done is then also further including MDs in framing in how we're going to use our prediction model. So when we had a model running on more than 500-600 variables, we needed their inputs in order to shrink the model so it could be feasible in a clinical setting. So when we are running it now, as we are here for the 7, 8 months actually since 1st of February, we have made this arbitrary division of patients according to their risk of mortality, below 1%, 1 to 5%, 5 to 15%, and more than 15%. The doctors have been involved in the shrinking of the models and the phenotyping, and also giving us input into what would be the right classes of risks which we could act upon with some optimization according to the risk of the patient. So if the patient had more than 15%, we did a lot of stuff on these patients in order to improve their conditions before surgery. So last slide here, we have run through 154 patients, and what we see is there is a reduction in length of stay after surgery, there is a reduction in readmissions after surgery, and we also have a reduction in morbidity. All this, I think, if I were to make a conclusion, is kind of good results. It's definitely have provided value for my clinical practice. And I can also share with you guys that it has been an amazing trip. So having this involvement and having these important discussions with Patrick, with the team from Erasmus and different members of the community, getting in a place where we now can actually say that we have converted the whole knowledge creation into clinical practice has created a lot of traction in the Danish setting. And now we are doing what I think is the most important thing, is scaling up and seeing how can we involve this into different other use cases, so other cancer types, other surgery types, because it is actually now, due to what we have done, a pretty much plug-and-play solution that we have created for the healthcare sector. So coincidentally, being a research group outside Copenhagen, we actually have created a solution for implementing personalized medicine in the clinical setting. And this is me being modest. I could say much more crazy things, but I'm very happy to be a part of this. And I want to thank you all guys for the excellent work that has made this possible on a community level. And I've been enjoying the ride, and hopefully we can share experiences in kind of framing this and scaling this in the future. So that was the last words from my side. Thank you very much.
Thank you so much, Ismail. It's amazing work. I mean, when you think about the OHDSI mission of collaborating, generating evidence that promotes better health decisions and better care, I mean, this is proof that what we're doing is working and advancing our mission. So thank you so much for sharing, and congratulations to you and your entire team. Next up is our Titan Award winners for data standards, and that is Gowtham Rao and Azza Shoaibi. I believe you should be seeing my your slide, not mine. So you can take it away.
Thank you, Craig. Wow, it's hard to talk after how inspiring the clinical application Titan Award was, but here Gowtham and I are just gonna take this time and just talk a little bit about our journey with OHDSI, and we picked some pictures that really take picture of every OHDSI Symposium since the day we joined till the last one last month. I'm just going to walk through it because it talks a lot about everything that OHDSI means to us. And so in the first picture here, you see our very first tutorial in 2016. That was our first symposium as well. I remember that day very clearly because Gowtham and I had to stand in line in that door that you see behind us for about 10-15 minutes, trying to push our way in because we were waitlisted. We didn't make it. We didn't register early enough, and there was limited spaces, and so we had to wait begging to get in. And people were nice enough. Maura was nice enough to finally sneak us in 10 minutes after the session started. And we were in, and we attended. It was a tutorial for Atlas by Chris Knoll and others, and that was the first time I personally touched Atlas and get to do some stuff. That was 2016, and fast forward to 2023. That the last picture you see, that's Gowtham and I after our work group and tutorial that we gave last October. Also using Atlas, but in a very different skills, I would say, at that point. So that's the journey from 2016 to 2023. That before that symposium, that 2016 symposium, it was in January of the same year, so about 7-9 months before that I heard of OHDSI my first time. It was a conversation that Gowtham and I had while driving from Columbia, South Carolina to Charleston, South Carolina. We were driving there for me to have my interview for my postdoc. Gowtham mentioned something about open science and a common data model. I did not know what a common data model is or what open science is. But he mentioned that the head of the lab that I was interviewing for is interested in this new community called OHDSI that is doing some really interesting work. And I remember him saying, think about really taking that postdoc if you get it, because if you get to get involved in this community, it will be very interesting and maybe will change our future. So I took the postdoc. And from January 2016, that was the first when I joined my postdoc in my lab that was interested in OHDSI and was ETLing the hospital data we had into OMAP. From that January 2016 till that symposium in October of 2016, literally, I was busy planning our wedding, but Gowtham was playing in our living room every single night, random tutorial and videos from a person called Patrick Ryan and people like Chris Knoll and Peter and Jenna talking about PLP, Atlas, tools. Those tutorials were running in our living room every single night. The voices of these people were in my head. So when I met Peter, I remember in that symposium of 2016, and I talked to him, I was like, oh my God, I know your voice very well. And Jenna, the same thing. I knew these people's voices just because we listened to so many material before we attended that 2016 symposium. And in that very first symposium, that was 9 months after I started my postdoc and exactly 2 months after Gowtham and I actually got married. And so we had just started our life together and I started my professional life. So the journey you see here on these pictures is obviously very personal to me and to Gowtham as well, because literally, if you track those pictures and if I track the symposiums since 2016 to today, it tracks how both Gowtham and I grew up as a couple, as parents, as family, as scientists, as health researchers, every year, 1 year after in the OHDSI Symposium. So that's how personal it is to us. So the hook for me, and I'm going to keep going back to that very first symposium, but the hook for me was the closing talk of 2016 symposium. It was titled, "Oh, the Places You Will Go," referencing Dr. Seu's book. Only that talk was not by Dr. Seu, it was by Dr. Patrick Ryan. And I remember thinking, oh my God, the places we can go, the places I want to go, and the places we should all go through this community, because as Patrick always says, patients are waiting. And maybe it was something about where I grew up. I grew up in Palestine, and when you grow up in a place like this where there's so much suffering, it is very healing to contribute to something that is bigger than you and bigger than whatever you can do on your own, because on your own you can't move the needle. But OHDSI was my way to contribute to something. That became very real to me 4 years after that, when we all in the community came together during the pandemic to contribute to the fight against COVID-19. Now, you all are here on the call for a reason. You all already have your motivation, and you probably have your own story, which is similar somehow to mine. But the question is probably many of you have is how you get to learn all the great things and all the big things that the community has to offer, and where do you start contributing back? Because we know that collaboration and making your progress in an open environment and open science like OHDSI is hard. And we know this because Patrick told us this to us a month ago in his closing talk in 2023. It is hard, but we also, but it's important, and it's almost vital. So I will tell you what the approach I took to slowly move things, and that is focus. I learned from the work we did during the pandemic that if you try to break what you can do or what you want to do into small pieces, and maybe spend some time learning what the community has already done in that small thing you want to focus on, you can start moving and making progress. I decided to focus on phenotyping after our work in the COVID pandemic. I was interested in this because it is a problem. It's a very hard problem, but it's not an impossible problem, and it is a problem that needs us to collaborate to figure out things. So I started by just learning what the tools, where are the community in terms of phenotyping, and that took some time, just understanding where people have already made progress in. And then after that, started to think of break anything we need to do into small pieces. And maybe what I found very effective is Patrick's style in creating some initiatives aligned with those small objectives or small pieces that you wanna accomplish. Something like Phenotype February, or something like the SOS Challenge, or something like How Often, and those are just recent one, but there's many in the community history and journey where we're coming into small initiatives and try to gather people and rally around it. Create this sweet spot of a win-win situation where everybody who contributes wins something, and collectively we make a progress, even if small one. So that's the approach I've been taking, and I know we have a long way, but we all hopefully the community grow and we all grow as people. And every time I think that things are hard or I'm lost, and I'm sure many people feel like that sometimes in the community, I personally just close my eyes and remember the people in this community, because almost everybody I work with is inspiring, from Martine to Mike to Asya to Faiza to Erica to Claire to Anna. There's so many names and so many people, and each of them can just give you a push that you can be that person, and it's just one step at a time. Thank you. And I think that Gowtham can talk.
Well, I'm gonna move on to Jessie, just to make sure everybody has time. But thank you to Azza and Gowtham for all the work you've done, and congratulations. Next up is Jessie Tong, our winner for methods development, or methods research, excuse me.
Hi everyone, my name is Jessie Tong. I'm a 5th year PhD student from the University of Pennsylvania, and I started my OHDSI journey back in 2017. Back to that time, I just got my bachelor degree at UC San Diego in applied mathematics. I have no idea about what is like real world evidence, real world data, but back in that year, the symposium really opened my eye. And for the first time, I knew about like the real world evidence, how important and how impactful it is for the public health. And it was also motivated like by the collaborative environment here, and also the open science idea, and also impressed by like the people here, the passion they have, like how friendly they are. So now I'm a 5th year PhD student, and during the past few years in my PhD journal, I have been closely work with the people from OHDSI, and like during the past few years, OHDSI is always my motivation, and also my like be a big family for me to meet great and awesome people, collaborators, and data partners. And yeah, I'm very honored to get this award. And today I will talk about like 2 projects we have been collaborating with OHDSI and to apply our federated learning algorithms. Okay, so let me see. So the title for the framework that I'm going to introduce today for the federated learning algorithms is called the Distributed Hospital Comparer. It is a new end-to-end data aggregation approach for comparing hospital performance without sharing patient-level data. And when we talk about hospital comparison, it also names as hospital profiling. So it involves a comparison of healthcare providers' structure, process of care, or outcomes. And the goal of hospital profiling is that we want to compare the quality of care between different hospitals. And this is very important, not only for the hospital, they can improve their performance, but also this like results for hospital profiling is very important for the patients because they can know which hospital they can visit and to get better treatment. And there are some efforts have been made. For example, this website called medicare.gov. On this website, you can type into your zip code, your location, and then the website will provide you a list of hospitals nearby. And then you can choose the one that you would like to go based on some rating here. So this rating, for example, they use their death rate compared with the national rate. And if it's smaller, they will give them a higher rate. And then you can go to the one that you prefer to go. And not only for the website, there are also some literatures talking about how important hospital profiling is. For example, this paper published on JAMA Internal Medicine, they talk about the variation in US hospital mortality rate for the COVID-19 patients, and also some other top journal papers that talk about the relationship between hospital ranking and with the health equity, for example, the racial disparity problems. And when we want to do hospital profiling within the OHDSI community, for example, we do international hospital profiling, we do have some like practical challenges. First one is that we cannot share patient level data across different sites, especially like the international sites. And also the second challenge is the case mix situation, which means different hospitals would admit different different population. For example, some of the population will be more severe in hospitals. So if we directly compare different hospitals, the comparison won't be fair because some of the hospitals, they will treat like more severe patients. And to handle these 2 challenges, we come up with a solution. We call it the Distributed Hospital Comparer. In this comparer, we have 2 different modules. The first module is called DGEM, stands for Non-Iterative Decentralized Generalized Linear Mixed Effect Model. And here I want to mention that Generalized Linear Mixed Effect Model is considered as the gold standard method by the National Quality Forum for hospital profiling. So this is the key idea that we are going to use for hospital profiling here. And the second module, so for module 1, the DGEM module, we are able to achieve fitting the generalized linear mixed effect model by only transfer some aggregated data. For example, here in the pipeline, you can see we only transfer some common effects and some hospital-specific effects. And in the model, there are the coefficients of, for example, a linear model or a logistic regression model. So no patient-level data are shared in this progress. And in the second module, we adopt a counterfactual modeling idea. And this idea helps us to solve the case mix situation. And so what does the counterfactual modeling idea mean? It means that we can hypothetically assume that all of the patients from different hospitals, they can form together as a large whole population. And this large whole population can be treated under each site hypothetically. And then we can get their outcomes and then compare different hospital outcomes. And this comparison is fair because we are working on the same population. We are not like only work on a subpopulation, which might be more severe compared with the other hospitals. So by putting all of this module 1, module 2 together, the DGEM and also the counterfactual modeling idea together, we are able to handle these challenges. The patient level data cannot be shared and also the case mix situation. And by working with OHDSI last year back in May, led by Jenna and my advisor, Dr. Yongchen, we worked together to apply this method to study the COVID-19 mortality by working with a group of very awesome data partners. We started our recruitment back in last year, May, and we have 12 sites finally on board. And as you can see in the whole framework, we have a few rounds of communication. To be more specific, we have 3 rounds. So it took about 3 months for us to finish all of the analysis, transfer the aggregated data, and produce the final results. And in this process, we have our R package DGEM COVID build, and also we have our PDA, stands for Privacy Preserving Distributed Algorithm package build. And also we developed this website called PDA OTA, stands for Privacy Preserving Distributed Algorithm over the air. So here, by using this website, we're able to ask our data partners to transfer their aggregated data through this website by uploading the JSON file. So here, we really save a lot of human labor by like shooting a lot of email like within the group. Okay, so recently, when we dive further into
Jessie,
I
just want to hold on, Jessie. I just want to make sure everyone has time. So, but like 1 more minute,
sure.
okay?
Okay, sure. Yeah, very quick. So recently, we have been looking further into generalized linear mixed effect model, and we found that when all of the covariates they are discrete, we are able to achieve the estimation procedure and the downstream analysis for counterfactual modeling idea together as a single step. So it means that we don't need 3 steps anymore. We only require one single round without no initialization to achieve estimation and counterfactual modeling for hospital profiling. And we call this method one-shot lossless generalized linear mixed effect model. And recently we have been working with our data partners and do the hospital profiling again. And if you're interested in this project and you want to contribute your data to this project, please feel free to let us know. Thank you.
Excellent. Thank you, Jessie, so much, and congratulations. I already see somebody in the chat who's interested. So so please, if there are any questions, please add them to the chat. Next up, our Open Source Development Titan Award winner, Katy Sadowski.
Hey, everyone. My Odyssey started in 2018 when I was consulting for HSA, which is the FDA of Singapore. And HSA wanted to strengthen its post-market surveillance of health products by mining electronic health records. And we discovered that Professor Rae Wong Park at Azza University had been successful in setting up a network of hospitals in South Korea where he was able to do data mining. And so we invited him to come to Singapore and teach us about the OMOP CDM. So in January of 2018, he spent a week with HSA, and he brought 2 students with him, Sang Chan Yo and Shin Da Hye. And they spent the week teaching us about the ETL and vocabulary to the entire vigilance and compliance branch. And Mui Van Zant happened to be in Singapore at the time, and she also dropped in to share some of her wisdom. And while Professor Park was there in Singapore, he also met with people from the Ministry of Health who were architects of the Singapore Electronic Health Record. And so I think that visit was really important, not only for teaching us at HSA, but also for laying an important foundation for OHDSI to make inroads into Singapore. And in April, one of the HSA staff and we went to the OHDSI European Symposium in Rotterdam. I was blown away by the energy of the people at that meeting and the excellent talks and became convinced that OHDSI was the best way to do collaborative data research. And like Azza, I sneaked into one of the tutorials and learned about the ETL, more about the ETL process and the vocabulary. So that summer, we had the opportunity to hire a summer intern. And so we hired Harun Tahid. He was a Tunisian student studying in Singapore at ELNUS. He was a computer science major between his sophomore and junior year. And so what we decided was that we would do an ETL of one of the Singapore hospitals and then try to apply the programs that were stored in the OHDSI GitHub on characterizing treatment pathways, this very important early paper that came out of the OHDSI network. And so between his knowledge of computer science and languages and the clinical knowledge of the clinical pharmacists at HSA and myself, we completed an ETL of the tables that we needed to run the treatment pathways program. And we did that for type 2 diabetes. And this was the result. And what we found was that in Singapore, similar to the US and UK, metformin was the most popular first-line drug. But unlike the other countries, the other drugs used first-line were mainly the sulfonylureas, including a first-generation sulfonylurea tolbutamide. And that was very different than in the other countries. And so we saw that because of the transparency of the OHDSI documents, the programs in the GitHub, and the tremendous help that we got from our posts on the forums, that we could get this far in such a short period of time and be able to present our data in such a visually appealing way. So in early 2020, when COVID-19 hit, South Korea was one of the countries that was hit very early on because of its proximity to China. And Washington State was where the first cases were reported in the US. And then when the pandemic hit Europe, Spain experienced a very high number of cases. So by this time, I was working with the Bill and Melinda Gates Medical Research Institute, which is a subsidiary of the Gates Foundation. And I encouraged Professor Park and Chan to submit a grant to the foundation to do a refresh of South Korea's insurance claims database so that it would be ready for the OHDSI COVID Study-a-thon that was conducted in March 2020. And then I also reached out to the University of Washington Medicine, which was doing all of the PCR testing for COVID at the time, and suggested that they get their data into the OMOP CDM. I also was in contact with Danny Pietro Alhambra at University of Oxford, and he was aware of, or through his connections with the CityApp in Barcelona, he thought that this would be a really useful database to get into the OMOP CDM because it represented a lot of primary care data, which was a nice complement to the hospital and claims data from other OHDSI partners. And so he and Tolita Duarte Salas used their funding and were reporting every other week to the foundation. And they impressed them so much that the foundation subsequently supported the Sheila study. And one thing I learned during this period, that the only patient-level real-world data that the foundation had access to was from Cerner and Optum, which was mostly US claims data. And what they really needed to know was what was happening in the low and middle income countries where they invest most heavily. So I'm unfortunately, when I looked at the map of OHDSI collaborators at that time, there were very few collaborators in Africa. And so that was a gap that needed to be addressed. And in 2021, 2 African scientists, Nega Ghebreyesus and Ahmed El Sayed, started the Africa chapter along with OHDSI veterans Andrew Williams and Andy Cantor. And we were really excited to discover that even though there's still a lot of health data collected on paper in Africa, there's also many institutions that have electronic health data, and many who are trained in bioinformatics, public health, computer science, epidemiology, and the like, not only in Africa, but in the African diaspora. So I got involved because someone said, well, we ought to have an agenda before every meeting. And so I thought, well, I can do that. And so that's where I stepped in. And one of the major things we accomplished was to prepare these very succinct descriptions of the benefits of joining the OHDSI community. We wrote one for ministers of health and other data owners, and another one for researchers. And in this way, we could have a more consistent communication with people about the OHDSI community. And I'm pleased to say that there are 2 OHDSI networks in Africa. They actually started before the Africa chapter, but they have matured along the way and have been really wonderful participants in this chapter, sharing their lessons learned and inspiring other people. And we're finding that there are a lot of sites interested in doing an OMOP ETL, but they need funding. And so we also spend time trying to identify potential sources of funds to help them with their ETLs and also OHDSI training. And we've also done work to reach out to other African data science organizations and public health institutions. And we have this beautiful logo for our chapter, which was designed by Adam Boris from Morocco. So I'm pleased to say that the membership has grown a lot in the past year and a half. We now have 117 members representing all 4 regions of Africa, East, South, West, and North. 14 African countries and 13 ex-Africa countries participate in the chapter. So I'm also involved with the clinical trial working group because I used to do a lot of work in this space for biopharma and FDA. And the FDA requires that data submitted for regulatory submission be in a format called CDISC SDTM. And so we decided in this working group that we would work first on defining conceptual mappings and write a guidance for how you would transform data from SDTM to the OMOP CDM. And I have to say, it took us quite a while to actually get clinical data that we could work with. But about 6 months ago, we were successful in getting data from the Critical Path Institute. And they allowed us to have access to this TB-PAX data, which is a set of tuberculosis trials. And so we are working on doing the ETL, and this is a really good working group to join if you want to learn about the nitty-gritty of the ETL process. So I'd like to just end by thanking everyone who nominated me or supported me for this award. I really feel the love from the community for getting this award. And I've learned in my life that when I volunteer, I get back much more in terms of meeting new people, learning new things, and expanding my horizons. And I've certainly had that experience with the OHDSI community. And so I encourage you all to join and volunteer in whatever little way you can, and you'll be surprised by the rewards you reap. Thanks.
That's really well said, Cynthia. what we get back is so much in this community, and I think that's great to hear. It's so great to hear everybody's personal messages. I know, so we have one more award. It's the community leadership. It's by Nicole. I know we're past the hour, so people have to go. This was pre-recorded, so we'll have it on the community calls page later on. If you miss it, please come back. It's 8 minutes, and it does end with beer talk, so I hope people will stay if they can. I'm going to play it right now, and then we'll go from there. But otherwise, if you can't, it will be on the community calls page later. But again, congratulations to all of our Titan Award winners, and thank you for all the work you've done. On that note, I'm going to start the video, and I'll just look for somebody to give me a thumbs up that they can hear it once it starts playing.
I'm chapter lead for OHDSI Australia and part of the APAC community. So it's really my honour to be awarded the Titan Award for Community Leadership. Obviously, I feel like a complete imposter winning this award because I really feel like all I'm doing is hanging out with my mates and sharing a common goal, which is to generate evidence that people want. So, of course, I am standing on the shoulders of a giant in our community, and that's Mui Van Zandt, who won the award last year. And I remember Mui coming up to me back in 2019 at the Global OHDSI Symposium and saying, hey, we need to get these chapters across the APAC together and to really advance the work we're doing in the region. And that's what we did. And we were really lucky to have some great leaders in the community working together to really take forward the research and the collaboration that we have done so far and many more years to come. So I just wanted to quickly show you some of the work we did this year. We were lucky enough to have the APAC Symposium in Australia, in Sydney in July. Thanks, Sarah, for the lovely koala artwork, which we used throughout the symposium. So for those of you that don't know me, I started in the OHDSI community back in 2013 when I was at the Asia Famke conference in Hong Kong, and I met this guy, Patrick Ryan, and he introduced me to OMOP and the work that was happening in standardization. And of course, it really set me on this path I'm on today and introduced me, of course, to OHDSI. So if we fast forward to 2023, so 10 years later, here I am hosting an OHDSI conference in Australia. So the OHDSI Symposium, APAC Symposium, was a 2-day in-person event in Sydney, and we had 110 attendees. And it was really exciting to see the breadth of researchers that came from all over Australia, so every state except for Northern Territory. And we also had lots of international colleagues make the journey to Australia. So we had Korea, Taiwan, Japan, Singapore, Hong Kong, China, and we also had some participants from, of course, the US, the UK and Sweden. We had diverse participant representation, so lots of academics, but of course we also had clinicians and lots of students, regulators, industry, not-for-profit organisations, and of course OHDSI devotees and one consumer. We had 8 symposium sessions, 12 speaker presentations, lots of lightning talks, panel presentations, and so on. So we really had a great breadth of research that was presented and 21 poster presentations. And it goes without saying, of course, that a lot of this work couldn't have been done without our APAC steering committee. So I really want to thank all of those who were involved in the organisation. So the theme of the symposium was really about recipes, so recipes for generating reliable real-world evidence that can guide clinical practice, shape our health policies, and ultimately, of course, improve our patient outcomes. So we talked about what ingredients we needed and of course, high quality data that captures the full spectrum of healthcare experience. And then there are instructions and there are ways that we can generate those ingredients into evidence. So the steps along the way to collaborate, to standardize, to spice our recipes with innovation and do those cutting edge implementations and best practice techniques. We talked about plating it up and how we can present those results to the people who want to consume our evidence. And talking about consuming, we really had a great panel presentation about the participants in our research and all of those people who need our evidence to consume in different ways. So we had a panel with regulators and policymakers. We had representation from patients and consumers. We had clinicians, and of course we had researchers. And we talked about different ways and the formats in which we need to package up or plate up evidence so it can be consumed effectively by the different stakeholders. Of that panel discussion, we actually talked about a proposed new OHDSI work group, which I'm really keen to get started and would really love some participation and help with it. And we proposed a knowledge translation work group, and really the aim of this work group would be to package up our results and make our results and our efforts and our work accessible to those different stakeholders, and in a way that they can consume it with confidence and the way that it is going to make impactful impacts on healthcare. So of course, as all good OHDSI symposiums do, we had a closing session, and it goes without saying that beer is very important in Australia. So we took the idea of the recipe and we encapsulated that as a metaphor for our journey together in the pursuit of real-world evidence. So I thought I'd just quickly go through that closing speech for those of you who weren't lucky enough to be here in person. So imagine, if you will, the raw ingredients of beer: malt, hops, yeast, and water. Each has its own potential, but it's not until they're brought together, carefully nurtured and processed, that they form something greater. It's much like the data we handle every day, raw, disparate, and perhaps unimpressive in isolation. But it's what we do with the data, how we treat it and transform it, that allows us to unlock its potential and turn it into something truly substantial, evidence. So the brewing process is a symphony of science and art, and in many ways, our work is too. So just as the brewer carefully selects the grains and hops and yeast, we choose our data sources and our methodology and the questions we wish to answer. It's a delicate process of fining and filtering and fermenting. Just like the brewer, we wait patiently as our algorithms churn, distilling the evidence from raw chaotic data, transforming it into structured, meaningful evidence. Just as each beer has its own flavour profile, each piece of evidence we gather has its own unique context and meaning. Some might be strong, impactful, altering the course of patient care. Others might be subtle, a quiet nudge towards new hypotheses or different approaches. But each in its own way contributes to the rich tapestry of medical knowledge. So we in OHDSI are brewers in our own right. Our ingredients are data, our craft is science, and our brew is evidence.
Oh.
And don't forget, beer is meant to be shared, and that's exactly what we did. OHDSI is about community, collaboration, connection, and just as beer brings people together, our shared mission of improving healthcare through observational research unites us. We're not just individuals working on separate projects. We are a community, a team, and leveraging our combined skills, knowledge, and passion to create real-world impact. And of course, this is our OHDSI Asia Pacific beer that we brewed, AI to PA. And we definitely shared that together at the drink session after the symposium. And lastly, I'd just like to say on behalf of all of the APAC chapter leads that we are trying now to come together. We have the ingredients and we now just need to generate the evidence. So watch this space for more collaborative studies across our region. So thank you so much. Again, I'm really honoured to have received this award. Thanks very much.